Children's Hospital to introduce our speaker. Thank you, Pam.
Thank you, Julie. Yeah, look, I have the great honor of introducing Claudette Poole, who is a pediatric infectious disease specialist at the Children's Hospital of Alabama and is also an academic with the University of Alabama at Birmingham. So she has many publications and has many interests in viral infections and antimicrobial stewardship, which I think this talk would be very salient, because I think it's very difficult to know when to reach out for the acyclovir. So without any further ado, Claudette is going to be telling us how to manage empiric acyclovir use for neonatal HSV. Thank you. Over to you.
Thanks, Pam. I'm just going to share my screen.
Recording in progress.
Great. So I just want to make sure everybody can see my screen. Pam, it's a go. Okay.
Really good. Yeah.
Perfect. Okay. So thank you for that introduction. Just again, some context. I do work together with both Rich Whitley and David Kimberlin. Both of these physicians are really the world experts in neonatal HSV disease. And Dr. Kimberlin very kindly shared his slides with me, many of which I've used for this presentation. So I really wanted to review the data we have to date and go through some of the seminal studies as well as some of the observational studies to help us think through when we should be thinking of neonatal HSV disease in infants, so that we're starting acyclovir early, appropriately, to improve outcomes. Oh, come on. And why slides on it? Okay, I'm having difficulty advancing my slides. There we go. Perfect. So I have no financially relevant relationships to disclose, but I do intend to discuss some commercial products and services, both diagnostics and antiviral therapies. So I thought I would start off with just discussing neonatal HSV in the context of neonatal sepsis, because that is how these babies are going to present. And to get an estimate of global estimates of neonatal sepsis, I found this study looking at a meta-analysis of 26 studies, where the estimate was somewhere between 1,800 to 4,000 cases per 100,000 live births per year. And the mortality rate in this meta-analysis was somewhere between 10 to just under 30%. And this is a global estimate. It's somewhat higher than the global burden of disease estimate, which gives us about 1.3 million annual incident cases of neonatal sepsis worldwide, of which over 200,000 result in death of these newborns. There's lots of gaps in this data, however, largely due to lack of standardized definitions for sepsis, whether we're looking just at early or late onset sepsis, looking at rates in preterm versus term newborns, and then if you just focus on hospital versus community rates of sepsis. So lots of gaps in the data, but it gives you an estimate. If we look at neonatal HSV disease, again, there's really a paucity of data on good estimates of this specific disease. Looker et al. Did a really neat study where they looked at the seroprevalence of HSV in women of childbearing age And then extrapolating known on transmission rates, they came up with these estimates of neonatal HSV disease, what we would expect to see in the various regions of the world. And by their estimates, we have somewhere between just 3.5 to 36,000 cases of neonatal HSV disease worldwide. So you can see it's really, we're all over the place. Looking at the data a little differently, looking at overall burden of disease, so absolute numbers of cases, the estimated largest numbers would be in Africa. But in terms of incidence rate, the thinking is that the Americas have the highest incident rate of neonatal HSV disease. And that's largely due to changes in the epidemiology or the acquisition of HSV1 and HSV2 in women of childbearing age. And that has bearing on the type of disease that's going to manifest in neonates. So Manhanat et al. Looked at Medicaid claims data. So this is in the United States. And this Medicaid is the public insurance. So this would be all newborns born in the United States not covered by private insurance. And through this data, so these are babies that were coded as having neonatal HSV disease. And you can see from 2009 to 2015, there's been a steady increase in the incidence of HSV. So we're at around about 5 per 10,000 live births, or that's roughly 53 per 100,000, or you can look at it at 1 to just under 2,000 live births. So it's still a rare disease, but not that rare. You will certainly encounter this in your practice. Jones et al. Looked at population-based surveillance in Australia. This was data from 1997 through to 2011. And based on this data, the estimate for Australia was between 3.27 per 100,000 live births. And over that entire time period, the mortality rate was just under 20%. Over that time span, however, we've seen an overall trend in improved mortality, and that's largely due to the introduction of high-dose acyclovir and the changes in recommendation of that dosing and duration. So the mortality rate steadily fell from 25% to 11%, which is remarkable. In the United States, from 2009 onwards, the mortality rate for HSV disease is roughly 6%. And you can see it stayed steady over this time period with no real improvement. And to understand neonatal HSV disease, it's the route of infection that we're talking about, the virus that infects a neonate really peripartum. So the infant gets inoculated as the baby passes through the birth canal or shortly after, versus the virus actually crossing the placenta. So it does occur where the virus can cross the placenta, but that really is the minority of cases. And that's true congenital HSV. The vast bulk of infants that are infected with HSV acquire it peripartum. To understand how the disease manifests, or the various different presentations, I thought it'd be useful just to remind ourselves of the pathogenesis. So the virus will inoculate the infant on the surface. It gains entry through skin abrasions. Example, the scalp electrodes is a classic site where the virus will inoculate. It can inoculate through the conjunctiva, mucous membranes. The virus will then start replicating in those local tissue sites, so in the skin and mucosal cells. And it's that local viral replication that gives you that classic vesicular rash. But there will also be an associated viremic phase. That viremia can result in that virus disseminating to organs. And if the virus then sets up within that target or end organ and starts replicating, it can cause end organ damage. And it can be widespread. It can involve the liver, bone marrow, lungs, brain. And that is manifests as disseminated disease. Alternately, if the virus is maintained during that viremic phase and does not actually invade tissue organs and set up destructive replication, the virus can travel along the nerve route from the mucocutaneous site, travels up centrally to the brain, where it will start replicating within the brain parenchyma, and those are the babies that present with encephalitis. And the clinical course in each infant will be influenced by an interaction between the pathogen and host factors, and will include things such as prematurity, birth weight of the infant, if there are any pre-existing protective antibodies that have transferred from mother to baby, timing of initiation of treatment, amongst other factors. In our current era of antiviral use, when we look at the presentations of type of disease in infants, it roughly breaks down to about 25% of infants will present with disseminated disease at time of presentation. And these are the sickest of infants. They'll often present with disseminated intracoagulopathy, pneumonia, hepatitis, and the majority of these babies will also have CNS involvement. Then 30% of infants will present more with just encephalitis. So this is where the viral replication has predominantly affected the CNS. These infants will often present with seizures, lethargy, irritability, poor feeding, or temperature instability. And the majority of babies will still present with disease that's still isolated to the skin, eye, mouth. So babies can present with classic vesicular rashes or keratitis, or they may not have any skin lesions, as I will go on to present. So the mortality and morbidity of neonatal HSV disease really depends on the type of disease at presentation, with the skin, eye, mouth having the best outcome if treated appropriately, disseminated having the highest mortality, and CNS disease having the highest morbidity in survivors. If there's any delay in initiating acyclovir, if the dose or duration of acyclovir treatment is inappropriate, and then the sort of morbidity is heavily influenced on whether we do post-treatment acyclovir suppressive therapy. So this is data from the original studies done through the Collaborative Antiviral Study Group. So these were large international placebo-controlled trials. The original studies with acyclovir were in comparison to vidarabine. This data that I'm presenting here is the comparison of the standard dose of acyclovir that was originally used, and then compared to the higher doses. And it's this study that really established 60 milligrams per kilo per day, or the 20 milligrams per kilo per dose given 8 hourly as the standard of care for neonatal HSV disease. As you can see, in disseminated disease, there was a dramatic improvement in mortality. CNS disease, again, the mortality rate overall for CNS disease is lower, but the 60 milligrams per kilo significantly improved mortality. So what about morbidity? So we've been able to prevent these babies from dying or improve the mortality rate for these babies. However, the outcomes are largely neurologic or developmental, and there's still morbidity in babies that survive this disease. When they looked at the original data of babies that were classified as skin, eye, mouth, so those were babies that did not have evidence of CNS disease or disseminated disease at presentation, when they followed those babies out, a small percentage of them still went on and developed seizures or developmental delay. And going back and looking at the samples from those babies, the original studies were done before PCR was widely available. So there were some infants that had PCR been available at the time, they would have probably been reclassified as CNS disease. But even those that tested negative retrospectively, there definitely is a risk of babies developing poor outcomes. And it was Whitley et al. Who really demonstrated that it was the reactivation of the virus, which manifests with cutaneous recurrences. If that virus is reactivating frequently, it was associated with worse neurologic outcomes. So the babies who had 3 or more recurrences after their initial disease were the ones who had significantly worse neurologic outcomes. So this is what led to further studies to see how could we improve outcomes for these babies beyond just survival. So again, this was showing the neurologic outcomes of babies 12 months out, between the skin, eye, mouth disease with the low dose and the high dose acyclovir, but CNS disease and disseminated disease. And it led to the trial looking at suppressive antiviral therapy. So again, to understand the time when this study was designed, it was already recognized that if a baby developed a skin eruption or recurrence after their initial disease, you would start them on acyclovir suppressive therapy. The investigators, when they set up this study, was really to see if you started suppressive therapy immediately at the end of treatment versus waiting for that first recurrence to start acyclovir, could you improve outcomes? And the columns that I present there in the middle, where we're comparing the CNS disease morbidity, so the infants that develop normally are depicted in yellow, mild impairment is in pink, moderate in green, and severe in red. You can see that morbidity wasn't significantly different in the low dose versus high dose for CNS disease. However, when you look at the data for infants that were randomized to receive placebo immediately post their treatment versus those that were started immediately on suppressive acyclovir, a substantial increase in babies developing normally 12 months out was demonstrated. I do want to point out, however, that the numbers of enrollees was very, very low. And I think that just speaks to how difficult it is to be able to do these trials. My understanding for this one in particular, it took over 11 years to enroll all these participants. This is a different way of depicting the data where they were looking at the Bayley mental scores at 12 months. Between those randomized to receiving acyclovir immediately versus placebo. You can see that with infants with CNS disease, they reached statistical significance. They were not able to demonstrate that in skin, eye, mouth disease. But again, the numbers enrolled were very low. Looking at the incrementally higher Bayley scores with longer antiviral suppression, you can see that the infants who were able to remain on active suppression for the full 6 months achieved the highest Bayley mental scores 12 months out compared to those with no active suppression. This again is a depiction of the duration of how long the babies were free of a skin eruption or a recurrence of a skin eruption between those who received acyclovir suppression versus placebo. Another piece of data, which I think is very important for clinicians to understand, is PCR results post therapy from CSF specimens. If in infants where you obtain CSF at the end of therapy for CNS disease, if you are still able to detect the virus at that time, it was significantly linked to poorer outcomes. And it's this data that has led to the recommendation to obtain that repeat lumbar puncture at your end of therapy to document clearance. If you're still recovering virus at that time, you need to extend treatment for an additional week, retap that baby. If you're still finding virus, extend treatment. And ultimately, we want to have a negative spinal fluid before we step down from the high-dose IV acyclovir to suppressive therapy in an effort to improve outcome. So this is a case that Dr. Kimberlin presents. It's a baby that he took care of back in the 2000s. And it really illustrates a couple of points of how neonatal HSV disease presents and what the sequelae can be and why treatment recommendations are the way they are. So this infant was born at 34 weeks gestation, presented at 16 days of life with a low-grade fever and a vesicular rash on their back and behind their ear. At presentation, clinicians swabbed the lesions and sent it for viral culture and started the baby on IV acyclovir. And at the time, the dosage recommendation was the 30 milligrams per kilo per day. The following day, the baby had a seizure, and so a head scan was obtained, and the image is depicted there, which was read as normal. A lumbar puncture was obtained. The white cell count was 33. It was lymphocyte predominant. The protein was marginally elevated at 143, and there were no red cells. The baby continued on the acyclovir for 8 days. On the 8th day, a covering neonatologist who had not seen the baby initially was following up on lab results and found that the surface HSV culture was negative and the CSF HSV PCR was negative. So the acyclovir was stopped and the baby was discharged home. The baby then represents at 12 weeks of life with a recurrent vesicular rash now on the baby's hand, and the baby was seizing. A head image was obtained, which showed this large lytic lesion in the brain parenchyma. A swab was obtained of the hand at this time, and at this time, the viral culture grew HSV2. And I think the points that really are illustrated by this case is that HSV testing is not absolute. So you can have false negatives. Certainly viral culture can be tricky if the samples are not handled correctly and received in the lab correctly or not set up correctly. You can have a false negative viral culture. Certainly CSF HSV PCRs, if obtained very early in the disease, can frequently be negative. And then neuroimaging at early presentation of neonatal HSV disease is typically normal. This case perfectly illustrates how lower acyclovir dosing and the shorter duration is insufficient to abort viral replication in the brain. And if left untreated or insufficiently treated, HSV is a very tissue-destructive virus that has a predilection for the brain. And this is really what led to the rationale for the longer duration of therapy. We now use high dose for 21 days, and then we will put the baby on suppressive oral acyclovir for an additional 6 months. And it's that 6 months of oral suppression that is really trying to prevent reactivation of the virus in the brain parenchyma, which is believed to be the cause for the poor neurologic outcomes. So looking at risk of transmission. So historically, we've always sort of been on high alert to infants that were born to mothers with known herpes disease. However, this seminal study illustrated that women with herpes will frequently shed virus subclinically at time of delivery. So this study attempted to obtain viral cultures from the genital tract around time of delivery. So they were able to capture just under 40,000 women at time of delivery, of which 128 were shedding virus from their genital tract with no apparent herpetic lesions. On that cohort, they were able to collect serologies. So this is to understand transmission risk. We really want to classify whether a maternal herpes infection is a primary infection or a recurrent infection. And then if the primary infection, is it a primary HSV2 infection in the context of a woman who already has antibodies to HSV1 or vice versa, or if it's truly a primary where she's had neither HSV1 or 2 prior. And the reason that's important is because the transmission risk to the baby is vastly different. So going back to the study, when they looked at women who were shedding virus and they could compare it to the antibodies present in that woman, they found that women who had a true primary infection, so whether it was HSV1 or HSV2, she had never been exposed to herpes virus before, the transmission of herpes to the infant was close to 60%. If we look at a non-primary HSV1 or non-primary HSV2, so this is woman shedding a virus where the opposite HSV type antibody is circulating in that woman. So the classic was a woman had acquired HSV1 in early childhood. She has antibodies to HSV1. She then acquires HSV2, which she is shedding at time of delivery. That risk goes down dramatically to the infant. So the rate of transmission was roughly 25% in those infants versus the true recurrent HSV. So this is where a woman is known to have the herpes infection pre-pregnancy. There's concordance between her antibodies and the virus that she's shedding at time of delivery. These are classically the women that will manifest with genital lesions. The risk of transmission to those infants is roughly 2%. So this study clearly demonstrates that the babies that are most at risk of neonatal HSV disease are actually in the women who have no prior history of herpes disease. They acquire it during pregnancy, and the vast majority of those women will have no genital lesions at time of delivery. So there's no real history to trigger you to know that this baby is at risk for HSV. So the question then becomes, well, when are we supposed to think of neonatal HSV? This study published by Long et al. Looked retrospectively at their data. So from 1988, at their institution, they just decided to empirically consider HSV in all infants presenting with a sepsis-like picture, less than 60 days of age. All those babies were going to get blood cultures, urine cultures, lumbar punctures, HSV workup, and were started on ampicillin, gentamicin, and acyclovir. And what they found from this cohort is during that time frame from 1988 to 2009, they had 32 cases of documented neonatal herpes disease. 31% of them had skin lesions or eye findings, 19% had seizures, and 50% had non-specific findings. So they either had fever, hypothermia, or poor feeding. In that cohort, clinicians had originally documented those infants as appearing non-toxic or non-ill appearing, and 90% of the cases had onset of symptoms before 21 days of life. And their entire cohort of infants worked up for sepsis. 1.33% of that group ended up having neonatal HSV disease. Brower et al. Did a similar study. It was a single center 5-year retrospective review. Again, all infants under 60 days of age undergoing an evaluation for serious bacterial infection. They focused in on infants that were presenting at less than 28 days. So their cohort included 934, of which 19 were diagnosed with HSV disease. Again, all of them had symptom onset before 21 days. In that cohort, the incidence was roughly 2%. Again, a third had skin lesions, 16% had seizures, but their group assessed their infants as largely ill-appearing. If we look at preterm infants, again, not a lot of data. This was a study published a little while ago by O'Riordan, again, a retrospective single-center study, just focusing on infants born less than 37 weeks gestation. In this cohort, they had 10 singletons and 1 set of twins. None of these mothers had lesions documented at time of delivery. These infants were all born to young mothers. All the infants were admitted to the units on the day of birth, and 10 out of the 12 were actually intubated on day of life 1. So all these infants were essentially sick from birth with respiratory symptoms. The gestational age of this cohort ranged from 24 to 35 weeks. A clear deterioration of these infants had occurred somewhere between 2 to 13 days, predominantly described as worsening respiratory status, hypotension, and lethargy. Only 4 out of the 12 actually developed a rash. 10 out of the 12 were treated with acyclovir. And again, looking at the dates, you'll understand why only 3 received the higher dose, and only 3 out of the 12 survived. So this has led to the development of certain algorithms to try help clinicians hone in on which babies truly should be evaluated for HSV. This is an example of such algorithm that has been implemented at Cincinnati Children's. They presented this study looking at how, sort of as a quality improvement initiative, how they could improve appropriate use of acyclovir, decrease the use of acyclovir in low-risk infants, and then improve adherence to doing a full HSV evaluation. Again, you can see they really target infants that are less than 28 days of life, because the risk of neonatal HSV is substantially reduced after that time frame. There are specific risk factors. So obviously, if there is a known HSV exposure, that increases the risk. If there is apnea in a formally term infant, poor perfusion, hypothermia, seizures, altered mental status, or any abnormal neurologic examination. Obviously, if you have a typical vesicular rash, poor healing at a scalp electrode site, or excessive bleeding, all of those would be considered high-risk factors. In their algorithm, all babies under 21 days of age would essentially get an HSV workup. infants that do get the CSF, if there's any abnormality on the CSF, again, babies should be evaluated for HSV and started on acyclovir. So depending on your definition of neonatal sepsis, the incidence of how often you would actually find neonatal HSV disease is somewhere between 1% and 3%. If you risk stratify, so really focusing on the ill-appearing baby less than 28 days, at least 5% of those babies will end up having HSV disease. Whether you're going to diagnose type 1 or type 2 will really depend on the epidemiology of HSV in your region. So certainly I know in Australia, the majority of neonatal HSV disease now is due to HSV1, which is true in America as well. Greater than 90% of cases will present within the first 21 days of life. It can present up to 6 weeks, but it's exceedingly rare after 4 weeks of life. And beyond 6 weeks, it's no longer relevant. Incidence of HSV is definitely greater in infants born prematurely and those with low birth weight. And I think the take-home message is that the majority will not have skin lesions at presentation, nor a maternal history of HSV disease. So I would advocate that any infant less than 42 days presenting with a vesicular skin lesion is HSV until proven otherwise. Same is true if the infant presents with seizures. In the sick infant, where you're doing a more extensive workup, if you notice hepatitis, so particularly the ALT, if it's 2.5 times the upper limit of normal, again, neonatal HSV should be on your differential. And then obviously any baby presenting with a sepsis-like illness with a known HSV exposure. So if the mother has a maternal history of genital herpes at time of delivery, or a caregiver has herpes labialis or whitlow or skin lesions, those infants automatically should get evaluated and treated. It's those without those classic features that become more difficult. So again, we highly recommend considering HSV in infants less than 28 days of age. So it's really those young babies, the first 3 weeks of life. If they're presenting with fever, hypothermia, lethargy, poor feeding, or apnea, so really the sick baby should be evaluated for herpes simplex. When you obtain the CSF, if you notice pleocytosis with a negative gram stain, you need to consider HSV. Certainly if you're obtaining liver functions and the ALT is elevated, consider HSV. And if you've started a baby on antibiotics and they decline despite your antibiotics and your cultures are negative, consider HSV. If you are doing the HSV workup, always get all of the studies. So we frequently encounter babies that have incomplete workups. And I think it's important to recognize that the testing is not absolute. And so if you recover HSV from any one of these 3 sites, you have made the diagnosis, and then the classification of the type of disease will depend on the clinical presentation. So if there are skin lesions, we request that you swab the skin lesion and send it for either PCR or culture, and then swab the conjunctiva of the eyes, the oral mucosa, and the rectum, and send that for PCR or culture, obtain a blood sample for PCR and CSF for PCR. And then start the acyclovir immediately. So do not wait for that HSV confirmation. The data is absolutely clear that every day delay in initiating acyclovir is linked to higher mortality and worse outcomes for the babies that do survive. So rather start the acyclovir. If all your HSV testing is negative and you have an alternate etiology, you can then stop it at that point. If the clinical presentation is truly consistent with neonatal HSV disease, we really recommend treating regardless of your confirmatory testing. So a baby with seizures and skin rash, even if the HSV testing is negative and you haven't found an alternate plausible explanation, it's better to treat than to not treat. Acyclovir is very well tolerated. Outcomes of undertreated HSV is devastating. So the classification of disease is really based on clinical criteria. So disseminated disease is if you have any evidence of organ dysfunction, so including pneumonitis. The minimum criteria to classify a baby as having disseminated disease is the elevation of the ALT. CNS disease or CNS involvement is if you have either CSF pleocytosis noted on your lumbar puncture, or the baby has seizures, or the HSV PCR is positive. So please note, it's any one of those three. If you have that in an infant where you've recovered HSV, for example, from the surface, that baby by definition has CNS disease. Skin, eye, mouth disease are the babies where you have excluded evidence of disseminated disease because there's no end organ dysfunction and they have nothing to suggest CNS involvement. And note that a positive blood PCR can occur in any one of those three forms of disease. So just recovering the PCR from a blood does not make it disseminated disease. I see that error occur frequently. It's really the classification is based on these clinical criteria. And the relevance of this is really due to treatment. So we are going to treat the disseminated and CNS disease with 21 days of high-dose IV acyclovir versus skin, eye, mouth disease, 14 days has been shown to be sufficient. Acyclovir can be nephrotoxic, so we need hydration and avoid other nephrotoxic agents. You know, the one that classically can cause trouble is if the baby's on acyclovir and gentamicin. We recommend monitoring your neutrophil count bi-weekly because acyclovir, especially the high dose, can drop those neutrophils. All infants diagnosed with neonatal HSV disease should get an eye exam to rule out keratitis because those infants will require topical antiviral in addition to systemic antivirals. It's best practice to get some baseline neuroimaging on these infants at time of initial presentation. MRIs are best. However, it does require sedation, so CTs or head ultrasounds can be acceptable alternatives. And that's really more for prognostication and for future comparison if those babies come back and represent later on. Like I said earlier, we really do need that repeat lumbar puncture in babies with CSF positive HSV early on so that we can document clearance to help guide how long to treat with IV acyclovir. And then all the infants get discharged home on 6 months of oral suppressive therapy. Sort of switching gears quickly, I wanted to talk about the data that came out to really help with recommendations of cesarean sections on moms that were shedding or had evidence of clinical HSV at time of delivery. This study nicely demonstrated that babies' risk of neonatal HSV is reduced if the babies are delivered by cesarean section, but it's not eliminated. So just because the baby was delivered by a C-section does not mean that they cannot get neonatal HSV disease. It just reduces the risk. The same is true for acyclovir suppression throughout pregnancy. Again, the data showed that it reduces the number of genital recurrences the woman has, which reduces her rate or risk of getting a cesarean section, but it does not eliminate the risk of neonatal HSV disease. So again, all these studies have looked at asymptomatic shedding of HSV in the genital tract on women who were treated with acyclovir throughout pregnancy. This is an algorithm that is presented in the Red Book, which is an American Academy of Pediatrics publication, but really is to try help guide how we manage babies that are born to women who have active genital lesions suspicious for herpes at time of delivery. Again, not all birthing hospitals will have the capability to do this, but this is just one suggested method of preemptively trying to screen the babies highest at risk of going on and developing disease, which, as I demonstrated in a few earlier slides, is highest for the women who have a first primary infection. So basically, you have to swab the mother's genital tract to type the virus, and you obtain serology on that mom. In the interim, you will, if the mother has no known history of herpes disease, you will obtain the full HSV workup on that infant and start them on IV high-dose acyclovir while you wait on the genital typing of the virus and the mother's serology. If you can demonstrate that there's concordance between the virus that the mother's shedding in her genital tract and the antibody she has, that puts that baby in a very low risk. As long as all the HSV studies on that baby are negative and the baby remains well, you can stop acyclovir and send that baby home. If you do not fall into that category, you can go on, and if the baby tests positive for virus, you're going to treat that baby as if they have disease. And it's those babies that don't test positive for the virus but are at high risk of developing disease, we go on and we treat them as what we call preemptive treatment. In the mother who has a known history of genital herpes, the approach is a little bit different. Again, at 24 hours of life of that baby, you will just swab the baby and obtain a blood PCR. You will not get a lumbar puncture on that baby. You will not start acyclovir on that baby. Again, as long as the baby's HSV studies remain negative and you have confirmed that this woman truly does have a recurrent disease, you will discharge that baby home. Certainly, if any of the infants' HSV studies come back positive, you will be getting a lumbar puncture on that baby and treating that baby as if they have disease. So the big difference is if the baby tests positive on any of your HSV studies, you're treating them as if, as you would for neonatal disease. It's for those babies that are born in that very high risk situation. So it's the moms with primary infection that you've proven by the fact that you've confirmed HSV shedding in her genital tract and she has no antibodies, or she has discordance between the type of virus in the genital tract and her antibodies. Those babies, it's suggested that you can treat them for 10 days with high-dose acyclovir and then no suppressive therapy because you have not documented disease in that baby. These are all my references, and I am free for some questions.
Thank you very much, Claudette. That was such an excellent, very well-connected, logical talk. I might just start off with a comment. So we have similar, we also have our perinatal algorithms for HSV, and you'll be very happy to know that we're pretty concordant, with some variation. So we also bring home or send home the take-home message that we need to marry the maternal HSV IgG with to determine risks to the baby. So type specific and immunoglobulin specific. We have as you've already alluded to, a much lower prevalence of HSV neonatal disease in Australia. I think we're 10 times lower than you. So we tend to do a little bit of variation in the asymptomatic baby. We don't give them obviously it's a discussion with the clinicians, but we don't tend to go with the full 10 days in the asymptomatic, but a lot of everything else, we line up, mostly because we use your Alabama guidelines. And for those in the audience, hats off Alabama. That was one of the publications, actually. But the Alabama group are probably the strongest in the world. They've done all the RCTs on a lot of the background work on HSV, as Claudette has outlined, and that's really built. They really build up. You really built up your stories on 3 decades of research. And needless to say, congenital CME, the same thing.
Yes.
Your group have all done that acyclovir, Gancalco, which has really helped us with management. May I ask just one question?
Yes.
The surface swabs at 24 hours, I've often tried to explain to, when we get consults, why we wait for the surface swabs of the babies born to, with at-risk mothers. Why is it we have to wait for 24 hours?
So the thinking is that if you swab early, you are just essentially picking up mom's genital shedding.
Yeah.
24 hours and beyond, you're picking up replicating virus from the infant's mucosal or surface sites, right? So that swabbing is you're swabbing the conjunctiva, the oral mucosa, and the rectum. And if you're recovering virus, then it's replicating virus in the baby's cells versus virus that the mom shed and has bathed that baby on. Because again, a lot of babies, HSV is actually very, very common. Depending on where you are in the world, yes, it fluctuates, it goes up and down. The transmission to the babies in the grand scheme of things is actually quite low, right? So especially in the babies where moms have antibodies. So back in, 3-4 decades ago, the epidemiology was little kids all got their herpes stomatitis, right? They all got their little HSV1 when they were little. And then when people became sexually active is when you acquired HSV2. But having that HSV1 antibody really decreases the risk of transmission to the baby. That has all changed now. We just have really altered the epidemiology of HSV. But again, it varies where you are in the world. So the way it manifests or the prevalence rate is very variable depending on where you practice.
Yep. So the upshot of it all for the audience is that HSV1 is becoming the more predominant strain.
Yes.
You've just altered the epidemiology, and HSV1 is more transmissible but less recurrence.
Again, so HSV1 evolved. These viruses have been around with humanity for millennia. HSV1 evolved to sort of set up latency in the trigeminal or, head and neck ganglia, and then reactivate periodically, and we shed it from our oral mucosa. HSV2 evolved really well to become latent in the sacral ganglia, and then would periodically reactivate and shed in the genital mucosa. But if you inoculate those viruses in the opposite sites, they just haven't evolved as well to set up latency and reactivate as efficiently as they do HSV1 in the oral mucosa, HSV2 in the genital mucosa.
Yeah, that's a really nice way of looking at it. Look, we've got a very good question in the audience. So Julie asks, some of the audience may not have access to viral testing. What would you suggest in those cases?
So PCR is becoming quite widely available. I would imagine there are places where you still don't have PCR. Viral culture is becoming much less common worldwide now. So, I would say the norm now is PCR, and viral culture is really falling in like research lab techniques. But that is really difficult. I don't know how you would successfully be able to identify a neonate early as having HSV disease where you can truly make a difference, right? So by the time the baby has the classic temporal lobe, lytic lesions, is seizing, you've lost the opportunity to actually save that baby's brain. So if you don't have HSV PCR capability and you're taking care of newborns, that's where I would really sort of strongly advocate for having that diagnostic available, because to wait for the classic features of HSV, you've missed the opportunity to actually change the outcome for that baby.
It's just based on high clinical suspicion, I think, and low threshold for starting. We've got some good questions here again. So a mum has a history of genital herpes. Oh, hang on, it's going too fast. So if a mum has a history of genital herpes recently, so I'm assuming that's primary HSV in the pre-birth period or recent antenatally, and has been on acyclovir prophylaxis, that's true, and gets an elective cesarean section, what would you do for the baby of that mum?
So I think a lot of it depends on whether she has genital lesions at time of delivery, right? So if she has a C-section and there has been no rupture of membranes, the risk of transmission to that baby is extremely low. If you have rupture of membranes for, they say, at least 6 hours or longer, even if the baby delivers by C-section, if the mom has active lesions, there's risk of transmission to that baby. But again, if she has recurrent disease, if she's known to have herpes, she had herpes pre-pregnancy, the transmission risk to that baby is very, very low. It's like less than 3%. So I think in that baby, if you don't have access to swabs or, the prevalence is extremely low in your setting, I think just close observation. If that baby comes in looking sick, but they don't have to look very sick, right? I hope I made the case that it can be hypothermia or apnea or just poor feeding is frequently how these babies present. If there's a known history of herpes, I would treat that baby for herpes as you work the baby up for other etiologies as well.
We've been very of recent times. I take your, so thank you. That was a great answer. We actually talking about trying to diagnose herpes. It's anybody's call sometimes, right? Sometimes you never find the herpes, although clinically the baby's looking like she's got a neonatal herpes. We just treat through. The testing for HSV is not absolute, especially CNS. Yeah.
Yes. So if it looks like herpes, I would say definitely treat regardless of your testing, right?
Exactly.
The problem, though, is that especially the CNS disease, if it's starting to look like classic herpes, your ability to change that outcome for that baby goes down dramatically, right? Exactly. It's the babies that do not look like they have herpes, that you do not have any risk factors for herpes. Those are the babies that I think, or it has been demonstrated that if you treat them early, you change their outcome.
There are two questions. One was actually for me, which I can answer at the end to Pramod. But Thomas wants to know, while waiting to perform a skin swab, or the swabs at 24 hours, surface swabs really, what immediate skin and mucosal decontamination do you suggest, if any?
Yeah, I mean, that's controversial, right? So, many would advocate bathing that baby post-delivery to sort of decrease the viral load. I mean, that seems like a reasonable thing, but I'm not sure there's any data to show that it actually makes a difference, right?
Exactly.
And there is data to show that you're influencing the baby's microbiome by early bathing that has, maybe longer term health consequences. So I know it is a common practice to bathe babies immediately after birth, but I think the preponderance of data is actually against that practice, not for that practice.
It's actually nasal, isn't it, Claudette? It's in here. Yes. Mainly, so you can look. The time's running. I might just very quickly answer Pramod's question. He's asking, why did we change our guidelines in the ACID ones? to not recommending surface swabs at 24 hours for the low risk babies. That's based on, so the American guidelines, so Claudette outlined, it's because they've got a much higher incidence of neonatal HSV infection. So in the low risk baby, so we've defined that as those with less than 2% risk, mother's got, protective antibodies, we've just recommended, it's an executive decision not to do a blanket recommendation for swabs. All right, it's 2 o'clock. Claudette, that was a marvelous, wonderful talk. Thank you so much. I hope you get to sleep time now. And thanks to the audience for great questions.
Thank you, Claudette.
Thank you.
Thank you, Pam. Great sharing.
welcome.